Morning, everyone. Welcome to today's webinar on mental health and mental disorders, hosted by the National Catholic Bioethics Center. Our guests today are Dr. David Chen, a psychiatrist practicing in Chevy Chase, Maryland, Dr. Karen Wenger, a faith community nurse educator for the Archdiocese of Boston, and Dr. Elliott Bedford, the Director of Ethics Integration for St. Vincent Health in Indianapolis and Ascension Via Christi in Kansas. I'm your moderator, Phil Cerrone. I'm an associate ethicist and the managing editor of the National Catholic Bioethics Quarterly here at the NCBC. And Sarah Czar, our membership director, will be helping moderate the questions at the end of the panel. By way of a short introduction, improving access to and the quality of mental health services are important public health priorities in the United States. Our guests will be discussing the ways in which the Catholic faith community can help achieve these goals, perhaps in a unique way. This discussion is based on the Healthy People 2030 objectives developed by the U.S. Department of Health and Human Services. This set of benchmarks is updated every 10 years by HHS and reflects the current state of public health and the goals for the next decade. The current national objectives focus on prevention, screening, assessment, and treatment for mental health and behavioral conditions. So without further ado, I'm going to turn it over to Dr. David Chen, who is kicking us off with a little bit about some of the challenges facing Catholic mental health practice today.
That's Mary Ann. Okay, glad we figured that out.
All right, Philip, thank you so much for having me as your guest today. Please let me know if the sound or quality is clear or not clear. I'm happy to make any adjustments that are necessary. Before I begin, I just want to start with a big shout out to all of us who are your audience today about the Eucharistic revival happening here in America. That's going to kick off on June 19th, 2022 on the Feast of Corpus Christi. It's very exciting. So it's very important, the very real presence of Jesus Christ in the Eucharist. This is everything for all of us. Also, this is going to be my first take-home message for us today. The second thing is to let everyone here know that by the Eucharist and the love of Christ in his sacrifice, that he loves every one of us here individually. And we need to remember that always in our conversation as we go forward on our topic today. Christ desires to heal every one of our pains and sufferings individually and to have a personal relationship with each and every one of us. So I want to structure my talk today onto three topics. The first topic is really to cover briefly about my background and also the background of mental health in America today. The second thing is really then to outline kind of the main challenge and the main problem for mental health care for Catholic America. And then the third is to propose the start of the conversation for us to think about what might possibly serve as a solution to these challenges. And here I'm going to propose one of my own, and the two speakers to follow will have other pieces of information that we could bring together and potentially through this discussion can come up with something that's really Holy Spirit led and very innovative. I got into medical school straight out of high school. There are programs in America where they allow you to do that. I knew very early on that I was going to go into medicine. The program that offered this combined degree was in Rochester, New York. I went there for college and medical school. I entered psychiatry primarily because in Rochester, I experienced a lot of challenge of a lack of cultural diversity out there. And so in a way, it helped me to really understand my background and its role in American society. I knew very early on that my desire is to actually treat families and also to treat young people. And so I went into medical school with the understanding that I was going to eventually become a child and adolescent psychiatrist. That's what I did. I did my adult psychiatry training at University of Maryland, Sheppard Pratt in Baltimore, Maryland. And then after I finished 4 years there, I went down to Children's Hospital down in DC to do my 2 years of child training in child and adolescent psychiatry. After that, I developed an interest in research and so wanted to look more into the genetics of mental illness. So that's when I went over to the National Institute of Health, the Institute of Mental Health, whereby I did my research work in bipolar genetics. The only note I want to make there is my work at NIH by 2011, me and my colleagues had found about 40% of all the known genes that are responsible for bipolar disorder. So right now, after leaving NIH, I've been in full-time private practice. I'm a member of the Catholic Medical Association, both the Baltimore Guild as well as the National, and I have a certification from the National Catholic Bioethics Center as well. So spend most of my time seeing adults, kids, adolescents, and their family. My practice now constitutes about 50% Catholic and 50% not Catholic. My primary focus, as my research was intended, is really in mood disorder, primarily bipolar disorder, but I also treat ADHD and addiction issues. So the picture of mental health in America is that roughly right now we're at about maybe 330 million Americans, and 1 out of 5 American are struggling with some kind of mental health issue. That's over 50 million Americans, if you do the math. 1 in 7 American struggle with mood disorder or some kind of anxiety disorder. So the problem when you have that large of a percentage of the population in America struggling with some kind of mental health issue is that when you focus in on the Catholic community, which if you look, there's about 70 million Catholics in America. So if you do the same 20% with mental health needs, that's roughly 14 million Catholics that are in need of help. The Pew Research in 2019 had identified that only about 30% of Catholics really believe in the real presence of Jesus in the Eucharist. So if you borrow from that number and you were to say that only 30% of Catholics in America might actually need a Catholic provider, which I think that's an underestimate, you're really looking at over still 4 million patients that are in need of a Catholic mental health provider. So what we're really looking at is in the main population of America, there is already a shortage in workforce providing mental health services. And when you now focus in on the Catholic community, the shortage becomes even greater. So just to give you a sense as to what that means to the average family or to the average patient, if you look at the numbers that are available that you could find publicly for the Catholic Psychotherapy Association, my last estimate is that their membership does not exceed 1,500 members. That's 1,500 members. So by my calculation, if you have each one of those therapists work full-time as a therapist in a reasonable way, like most therapists do in the community, they would be having to care for 60 to 80 patients at any time in their career for their career lifetime. If you look at what on average therapists do in the community these days, they're probably caring for no more than probably 20 to 30 patients or families at any time. So this is roughly twofold plus more number of patients. What this means is that then each patient will only be able to really see this therapist for less than 30 minutes per visit. Those of us who do psychotherapy, you need about a good up to 20 minutes to kind of get the session into the right spot. And then you need about 5 minutes to wrap up. So if you're operating under 30 minutes, you're not really able to do much work at all. So this would be unsustainable. Plus the therapists themselves would actually suffer profound rates of burnout. This would then create even a larger shortage, and then the vicious cycle would begin to build. The Catholic Medical Association could have up to about maybe 50 psychiatrists as members in the US. And you say, what? That's 50? Yeah, like if you actually look at the membership list for the Catholic Medical Association and you look around the country of the number of practicing Catholic psychiatrists who are CMA members, you're probably not going to get more than 50 individuals. So each one of them would have to see about 1,600 patients at any time in their career. This math actually looks more daunting, but a psychiatrist tends to see their patient less frequently, as opposed to like a therapist who sees patients on a weekly basis. So psychiatrists can actually see a patient every 2 to 3 months. So this means that each of these psychiatrists can actually see a patient for 15-minute visits on a 3-month cycle and be able to cover that number of patients. This is actually a doable model because back in the 90s, when HMO really tried to control psychiatric expenditure in the country, psychiatrists in mainstream academic departments were asked to see patients for only 7 to 10 minutes. So this is actually a potentially viable model, not ideal, but manageable. But however, if you're on the family side, if you're the patient or it's your child or it's your spouse, would you really want this kind of a care system? Would you call this excellent or even good? I wouldn't think so. So we need to come up with a better solution than what we're looking at here. So now on to a beginnings of the conversation of the solution to the workforce shortage. I would propose that a developing growing class presently in America, a growing class of bioethically trained spiritual directors can actually function as the ground level professionals that could be able to fulfill this gap in the workforce. So potentially what you can have is, because of the way that the training programs work for the spiritual directors and the lack of constraint in that population and the attractiveness of this certification is to the community, you could actually have a lot of spiritual directors trained. And then these spiritual directors can then interface with the communities either in school, through the church, parish, or through the archdiocese, and then be able to identify through screening instruments whereby they can identify individuals that are suitable for spiritual directioning directly, or those that may need additional testing for potential mental health care. And then those patients can then be referred to a psychiatrist for further evaluation. Those who could be deemed not needing full-on intervention could go back to their spiritual director. And then those who need continuous psychotherapy could then be referred to a psychotherapist. And then those who need to be treated medically can then be treated that way. This is a medical home model that is quite popular and actually very much utilized in mainstream medicine these days. And this type of medical home can be set up in schools, or you can set it up in the archdiocese, whichever location there is. So at the end of the day, what you'll have is a availability of local level at the most community level, providers who know the family very well, who can then help and guide and accompany families through their journeys in our pilgrimage back to God. Thank you so much, Philip.
Thank you very much, David. That was a very interesting suggestion about the multi-level of for screening. Our next guest is Dr. Karen Wenger, who is a nurse community educator, currently working in this field that we're talking about right now, addressing health issues, mental health issues in at the diocesan level. And she has done some interesting kind of anecdotal research in preparation for this webinar on what is already being done in parishes, what isn't being done, and what nurses currently working in the field think should be done. So Karen, thank you very much, and I look forward to hearing what you have to say.
Well, first of all, I am familiar with the medical home model that David spoke about, and I think his proposal is brilliant. And I see a place for faith community nurses in that model. So thank you, David. That was brilliant. About myself, I've been a nurse for 32 years. And when I was a new nursing student and a new nurse, I always said I would never do mental health nursing. It wasn't my thing. And after 32 years in the field, I've realized that every nurse does mental health nursing because it's everybody's thing. So I've been a nurse for 32 years. When I went back to school in 2002 to get my bachelor's degree, I heard the term parish nursing for the first time. And so I decided to look into it a little. Something about it spoke to me. Parish nursing has since been renamed by the American Nursing Association as faith community nursing to be more inclusive of other faiths besides the Catholic faith. But what faith community nursing is a way to put nurses into their communities of faith, whatever denomination, to do kind of some holistic health education, advocacy, not so much hands-on nursing, but more of kind of the spiritual stuff, like David had mentioned with the spiritual directors. I have since gone on, gotten a master's degree, and I recently finished my doctorate in care of populations. Our focus really is to look at population health and how do we bring that spiritual piece to the parishes, to the individuals in the pews, to the families, to the community at large. So as Phil said, Phil had sent us some questions, and I sent those out in an anonymous survey to other faith community nurses in my network in the New England area. Those questions followed there were 6 of them, and they followed kind of the outline that's here on this slide. The ones that are underlined are the ones that I have chosen to address. So as we go forward, I wanted to have a voice beside my own. I didn't want to just answer this from my own perspective and what I'm seeing in my own faith community. I sent out over 100 surveys and got about 20 to 25 responses. People either responded back to me via survey, or they texted me or emailed me or just called me and said, hey, this is what I think. I'm going to skip that slide because it was just the actual questions. So the way I kind of framed my response today is to address 4 of those questions and start by looking at the Healthy People Initiative, which I'm very familiar with when I teach faith community nursing. So my role as the educator is to teach nurses how to become faith community nurses within their parishes. And I do use the Healthy People Initiative in some of the population-based stuff that we do. So I looked at the mental health objectives for Healthy People 2030, and I was a little, I looked at the differences in the rates of who's being treated for depression. And I had to ask myself, why are there differences between the treatment rates for adults versus adolescents? And then I looked deeper at the rates of who's being screened. And as you can see from the slide, we're not screening people sufficiently. The primary care providers are just not screening sufficiently when people go in for their annual physicals. When we look at adolescents, 3/4 of adolescents are getting their annual physicals, but only 1/3 of them are being allowed to speak privately with their providers. And if you think about yourself as an adolescent, if you struggled with any kind of mental health disorder, how likely would you have been to tell your doctor in front of your parent, yeah, I'm depressed, yeah, I'm anxious? I personally would not have. We know that untreated mental health does lead to a lot of problematic behaviors, including substance use and other kinds of risky behaviors. So the question, and I just need to move all of you for a minute. The first question I wanted to address was, are there structures within the diocesan community or the Catholic idea of mental health? Is any of that conducive to addressing these issues? And so my network answered back with these answers. And so I really had to give this some thought. You know, we're not screening adolescents or adults sufficiently. We're not treating sufficiently. We have people being untreated. Is there something we can be doing at the parish level that could address this? So this to me screamed opportunity. So I'll move on for a minute. The next question then was, what can Catholic practitioners do to expand access? And I was intrigued by the responses I got. And this quote at the top of the page came through one of my anonymous surveys. And I wish I knew who gave me this quote because it's brilliant. People can't access if they don't know what's out there and available to them. So in response to the question of what can we do at the parish level, the responses from my parish nurses came back into 3 broad categories. We can educate, we can refer, and we can reduce stigma. And these are just some of the ways that we can educate. We can refer to local resources, again, if we know what's there. There was one suggestion to make sure that if we are going to refer people, that we really need to reach out to the resource ourselves and find out what are the requirements, rather than just tell somebody, call this organization and see if they can help you, to be able to kind of journey with them and help them get kind of that warm handoff as opposed to a cold handoff, and help people get to the resource they need. And then the other big thing was to reduce stigma and have open discussions, to ask our pastors and other members of the clergy to talk about mental health within their homilies, within the daily activities of our churches. Again, more opportunity. So I wanted to touch on the question as well, should we be developing greater partnerships among the church and the secular world of mental health? And by and large, people answered partnerships. And what they had to say about the secular world of mental health is that a lot of secular healthcare, mental health care organizations just don't understand or appreciate or value the role of our faith within our healing, and how important that relationship with God is, that relationship with Jesus, that relationship with the Holy Spirit, and that importance of prayer as part of our healing. There are those in the secular world who view religion as the problem and not the solution. And then there's that substance use disorder again that people were mentioning that is just so widespread. We know that mental health and substance use disorder are just, they're interconnected. Again, more opportunity. So what is being done at your parish? I got some nothing answers. I got some, well, the deacon and the priest address mental health issues. Nobody else does. I got prayer, which they're all valid, but the bigger answers came in through education and reducing stigma. And these, again, were some of the ways that we're educating and some of the ways we're reducing stigma. Now, some of my faith community nurses are school nurses at Catholic schools. So they're doing work with mental health counselors to help educate parents, to help educate teachers. We're doing peer groups, support groups, and prayer. The next thing I wanted to really kind of spend a couple of minutes on is an example of something that's actually being done at the parish level. And this is something near and dear to my heart. This is the Family Healing and Recovery Ministry. And I was trying to get a good visual of our flyer to actually put up here, but I do have the link to it here, and I have the link to our website. The Family Healing and Recovery Ministry was started by the mother of an addict as a prayer group of 3 people who came together to pray the rosary for families. And David, you mentioned families who are impacted by addiction. And over the past 9 years, this has grown to, before the pandemic, we were having 40 to 60 people come to a monthly meeting. We had expanded to 3 different churches. During the pandemic, we expanded using technology. We use Zoom, we use live streaming, and we managed to live stream our ministry to up and down the East Coast. We had people in Wisconsin, we had people in Canada, we had people in Florida who were live streaming us to participate in this ministry. And what we do is once a month we have a rosary with a guest speaker, and we pray the first names only of those who are struggling with addiction. And then afterwards we have food and fellowship. Then on another Saturday in the month, we have a mass strictly for families dealing with addiction. And again, we pray the first names of those struggling with addiction. And what this has done for so many people is it's given them a safe place to come to be with other people who understand their struggle, who understand the importance and the value of bringing their pain to the foot of the cross and laying that down at the foot of the cross and supporting each other. So if anybody, this is one of the things I really wanted to push my PowerPoint to Phil for. Sorry, I keep calling you David, Phil, I'm sorry. If anybody wants more information on this ministry, on how to start this ministry, please reach out to me and we can get you that information. We're going to have questions afterwards, so I'm going to leave that for now. But that's what I have. And thank you for your attention. I appreciate it.
Thank you so much, Karen. Real quick, before you, so we got a couple minutes left on your section. Could you say a little bit more about what faith community nurse education is in the United States? I know this was one thing that was very interesting to me when I was doing my research for this webinar, that in some places this is a resource and it sounds like a very exciting one.
So faith community nursing itself. So my role is just to teach nurses to go out and do the work. That's a little part of it. The bigger part, the more important part, is the nurses who actually do go out and do faith community nursing in their parishes. And it's a whole body, mind, spirit mentality. It's a whole body, mind, spirit approach where we recognize that, when somebody has, let's use cancer, for example. When somebody has cancer, they have a physical issue. They also have mental issues, emotional issues, and they also have that spiritual component. And we really try to strive to get that whole piece, to really meet the person where they are, to meet them in a safe place, to help them address some of the physical aspects of their illness, to be able to be an educational resource, but to also be that spiritual resource, and to really pull those two together and help people recognize that it's that whole person care, which kind of goes back to what David was talking about. That medical home model really is whole person care. This is just nurses doing it at the parish level. And we do that through the means of education. We do that through advocacy, through prayer, through support groups, through one-on-one work. It is a global initiative. It's a newer specialty in nursing. It's actually a specialty. I was an emergency room nurse. Emergency nursing is a specialty. Faith community nursing is a specialty, meaning once you finish school, you have to go on and take more education to become, to get education in your specialty. And in this country, there is a Westberg Institute for Faith Community Nursing, which sets a curriculum that I teach, but it's kind of the hub of where faith community nurses are around the country. And we literally are global. We have nurses in England, we have nurses in Korea, we have nurses in Africa, and one thing I found interesting is wherever we are in the world, we all have the same general issues. They might look a little bit different. We have the same issues to access to care, to access to sufficient nutrition and clean air and clean water, the real basic things that everyone struggles with, issues with violence. We all have those same issues with mental health. We have those globally. And the faith community nurse is there to be kind of a guide or a support, just to help people find the resources they need to help manage their whole person care.
Okay, thank you so much, Karen.
You're very welcome.
All right, our final guest for today is Dr. Elliott Bedford, Director of Ethics Integration at St. Vincent Health and Ascension Via Christi. And he's going to talk to us a little bit about his take on these 2030 objectives and from an integration perspective, addressing this issue from the health system perspective. Thank you very much, Elliott.
Thank you, Phil. Thank you, David and Karen. It's a great opportunity and pleasure to be with you all today. I want to commend NCBC on putting on a webinar on this particular topic. I think that it is extremely important, especially as we are dealing with the implications of the pandemic, the lockdowns, and all that kind of stuff. This is a burning issue of our time. And that's where I want to kind of start my comments, is to go back take a step back and really look at the why this should be a big issue for Catholic healthcare, Catholics in general, and the church as a whole. And I would argue that precisely because the church's understanding of human anthropology, what human beings are, whether it's divinely revealed or known through natural reason, really gives us a distinctive and advantageous understanding of what mental health issues would be, and then also the appropriate way to approach them in a whole person approach. So I think the idea that we recognize from the get-go that human beings are composite beings of body and soul, immaterial and material, recognizing that ultimately we are called to be well-ordered and live our lives as in a virtuous manner, pursuing spiritual goals, gives you the whole context for being able to understand why mental health ought to be right at the center of our concern for patients. And I would say that if you want to distill kind of a Catholic philosophy of medicine down into what's really distinctive about it, I would give you 3 areas of kind of service that would stand out as the Catholic philosophy of medicine really has a lot to say, something distinctive to say about that thing. The first one being beginning of life fertility related issues. So in that area, we have the natural family planning conversation, avoiding and achieving pregnancy, very distinctive approach there. End of life and kind of dealing with major illness. We have palliative care and hospice as a distinctively expressive way for the Catholic faith to be put into practice. And then I would argue in the middle, it ought to be mental health as our calling card, because of who we are and what we understand human person to be in light of church teaching. But when you look at the gap between the amount that the church focuses kind of explicitly on that need versus the potential in our church's teaching and understanding of human persons, that's where I see the biggest gap. We have the most opportunity to make up between the need out there in the community, and not just the Catholic community. We do it because we're Catholic, not because they're Catholic. The idea that we are going to help meet these goals of Healthy Persons 2030, we should be saying yes, because these are ultimately goals that are very consistent with who we would want. Some of the methodologies, the how, maybe might differ a little bit in certain areas, but whether they're worthwhile pursuing, whether in partnership or in individually, I think that the church's answer ought to be yes. But we've got a lot of way to go. So when I'm hearing David in particular talk about kind of a multi-pronged approach versus saying it's a overly medicalized approach where it's only access to the highly trained professionals, his proposal is more of there's different roles that people within the church that they can play. And I would fully agree with that. I've seen that play out, for instance, locally. So our facility in Indiana here has a mental health facility called the St. Vincent Stress Center. And in partnership with the St. Vincent Stress Center, we've had our local parishes come out and receive training, for instance, on the QRP, I forget what it is, but it's basically suicide prevention training, such that basically the trainee would be aware and be able to move the patient to receive appropriate assessment for further support. Rolling that training out to parish staff, parish ministry leaders, school leaders, and teachers, just so that you expand that network of awareness is the first step in being able to really let people be drawn in. So I think that there's something to that. And then I love the idea of leverage our unique capacity in the spiritual directors as another layer in that. It really speaks to, I just think, something that the church as a whole has a responsibility to respond to this. I mean, this is the model that Jesus himself walked around and did. So I think that it's only in our nature to be able to develop some sort of response there. I would also say that part of the issue that we do face, and working in the health systems, you do
Can I
find
use it for?
this kind of there's this common complaint of, well, it doesn't get, there's no money in it, or the reimbursement is not as high as you'd want in, say, like a cardiac service line or something along those lines. And that's another reason I think that you have to move to a more creative approach versus being boxed in by the culture that you're given. And that's where I would emphasize to this community, and along with the CMA, the CHA, that we have not only an opportunity, as Karen rightfully pointed out, huge opportunity. I think we have an obligation to be able to really put a lot of emphasis on increasing resources, decreasing the stigma. I think that's another fantastic point. But then also, helping people understand how this can be a ministry, a way to serve, to live out your faith. And I think that that's another way where it's moved beyond just kind of a medical career into, yes, this is something that we all can play a role in. So, because I get a little concerned if we look at it and say, well, it's only the health system's responsibility to help deal with that. When I'm talking to my psychiatrist over at the stress center, and he's saying anxiety and depression are something, it's one of the top, these are the top 5, or in the top 5 of things you're most likely to encounter in your kind of medical life. And I'm thinking, that's so many people that we don't have to wait until the house is burning down type of scenario. I see that a lot in ethics. We wait till situation gets really bad and then we ask for intervention. But what I'm hearing David and Karen and my friend Brian saying is there are things that we can do. They're not extensive interventions, but it is, being a helpful companion, sometimes just a listening ear to be able to address some distress, and then be able to, if you're appropriately aware, move them into maybe a higher level of intervention. So there's a lot of stuff that's involved with that. You need to be aware of what's available to you. But I just look at this and say, given who we're called to be as a Catholic faith, as a church, we have got so much opportunity and the responsibility to help others understand this is a way. And then I think this is a way to live out your faith. We're supposed to do this. But then I say, can you imagine if that were the case? If ultimately your parish became a place where it was known in the community that you could deal with your anxiety and depression and distress, and you talk about substance abuse and ways to manage that and recover from that. If your place, your parish was to become a place of healing, not only on a spiritual level, but on a physical level or a mental health level, think of how attractive that would be in terms of building up the kingdom of God in your local community. So that's a point I just really, really want to emphasize. This is not the health system's job alone. It has a role within the larger church, but this is all of our responsibilities in our various different capacities. So I very much support what David and Karen are saying in terms of not only the their scan of the kind of state of affairs of saying we're under-resourced, but also I love their creativity on how to look at this opportunity and think creatively instead of just receive the culture as it is. And that's another area that I'd want to kind of close on here is, so coming from the ethics background, a lot of time and energy right now is spent on hot button issues like gender dysphoria as kind of a, this is the issue that we really need to be thinking about. And I'll say, yes, it is. It's something there's patients that are suffering at the core of that issue, and that's who we're called to respond to as a faith. But I would say that if we focus exclusively on something like that, we miss this opportunity with, for instance, the anxiety and depression type of issue. Substance abuse is another one, where we don't have to go far to find out, somebody who is in need of support, suffering from those types of things. So it's not just the hot button issues that get a lot of attention, or that should get a lot of attention. There's a lot of stuff that people are suffering through that we need to be better at helping with. But even there, in the gender dysphoria debate or conversation, I would say that we have an opportunity.
How do you know?
We have an opportunity as faith
help here. I can't remember every little.
to recognize that rather than simply kind of receive the treatment alternatives that are given to us by a larger medical culture that we might necessarily not have the same values or even understanding of human persons and disorders, to be, rather than passive, we have a responsibility to be active and proactive in terms of developing treatment alternatives that would be consistent with our understanding of the human person and what helps them flourish. And I see the parallels, go to the natural family planning or to palliative medicine, and you see the clear, we've already started down the path on those two subjects. Palliative medicine versus something like assisted suicide. We're saying, well, we know that patients ought not be intentionally killed, and we also know that their pain and symptoms should be appropriately managed. So how do we find a way to really provide that good medicine? Calls us to a higher level of competency. Same thing on the beginning of life. Hey, we know that regulating birth ought not be involved, whether you're destroying intentionally someone's fertility or suppressing it, for contraceptive purposes. Okay, well, there's an alternative that we can still pursue the reasonable goal of, for instance, avoiding pregnancy when it's appropriate. And we can do it in a way that is reasonable and consistent with the dignity of the person. It's the same thing in the mental health category. There is absolutely has to be ways for us to use our creativity and the truth that God reveals through the faith to come up with solutions to address all of the concerns that we see on the Healthy Persons 2030. And I would much rather spend my time helping the church kind of identify and pursue those positive projects versus simply being passive and catching the culture and kind of arguing, well, can we, what are the limits to which we can adopt this proposal that's, being driven to us in the gender dysphoria debate. I think, let's spend our energy building is really where my message there would be. So that's where I'd want to kind of close it, is I think that it's such an important topic. We're only really just getting started, and I'm excited to see where we can use this as a springboard too. So thank you, Phil.
Thank you very much, Elliott. That was very good. Now we've got coming to our questions section of the webinar. Please send in those questions. We got plenty of time and plenty of space. The first question that comes in, this is really for everybody on the panel, so feel free to jump in. But would telemedicine be a potential way to reach patients as part of a solution to expanding access? David, let's start with you.
Sure. So I think that before we got started, Karen, Philip, you and I were having this very conversation about the role of telemedicine. I think that telemedicine is a very effective medium and instrument to reach regions of America where the access to a medical health provider in the conventional sense of the medicalized institutional medicine, where that availability is not available. But I think in Karen and my experience, since and of course, Philip, you and Elliott in your teaching and work as well, you'll see that there is an element that is subtracted in the interface with subjects in our interaction, in that being we are created in the image of God and the likeness of God, and that we are a community who believes in the reality of Jesus Christ and the reality in this world, that when we sit in a room and we talk to a computer, we know we're talking to a computer. It's not a human being that's in front of us. There is an element where we know that there is someone on the other side of the screen that does care for us, or that does want goodness for us. And intellectually, we can interface with that. But again, we are not a dualism. We are a reality, a composite reality, as Elliott said so eloquently. We want to have that corporeal presence with someone else. So I would say that telemedicine is a good backup plan. It's not the mainstay, in my opinion, in terms of reaching those who are out in the community. And I think having access to a spiritual director or a support group, as Karen so well articulated, would actually be the first go-to. Thank you.
Karen or Elliott, do you have anything to add to that?
I will. I've been teaching at a nursing college through the pandemic, and what David said is absolutely true. You absolutely lose something when you're communicating back and forth across a computer screen. Faith community nursing is so relational that you want to be with that person. I think telemedicine is a great backup for those places in the country where it's 100 miles to the nearest provider, for those times like the past 2 years when we've been in a pandemic and could not be physically close to people. But I think it's a substitute. It's not the best option.
I would agree that in a circumscribed manner, it can be very effective. For instance, we have critical access hospitals that are not going to be able to employ a full-time psychiatrist, but you get patients in the emergency room who have a psychiatric issue that needs to be dealt with in a relatively short manner. That's a very effective way of utilizing telepsych. But I think that if we don't let it, creep beyond its those kind of like ideal effectiveness pieces and say, well, this is the end all be all solution. I very much agree with the relationality, the incarnationality of being present with people. And it also means that what level of intervention are we talking about? So if it's just talking with somebody, like I said, with David, where it's just a session, or is it that, I've got somebody in acute distress and we need some sort of intervention and guidance? Those things should be taken into account as we're starting to think about the use of the telemedicine there. So I'm very supportive of it used in an appropriate and circumscribed way.
Excellent. Thank you so much. Our next question, and again, this is one that anybody can jump in at. I think we'll start with Elliott, though, because working with bishops and conferences is right up his alley. Are there any recommendations on what bishops and or state level Catholic conferences can do to support or encourage the solutions proposed today?
Absolutely. I think that, well, again, just using this as a springboard to say this is a profound issue that affects every community that we have in, our local churches. For the bishop to be the leader of that conversation and say that we have a special responsibility to have these conversations, help destigmatize, increase resources and training at the parish level, at the diocesan level. So in that sense, they can really lead by example, I think, in terms of things like the suicide, the QRP training, for instance, of why don't we have this for all of our diocesan staff, for instance. Could be a conversation like that. I think that helping, encourage, like local pastors, for instance, they're already dealing with addiction or mental health issues on some level at every parish. I think that that's just the reality. Karen, tell me that I'm wrong there, but I think that that's part of what it means to be, a parish priest. But I think a more formalized, organized discussion to help address questions like David's raising around how do we respond in a coordinated manner as a church that's not exclusively dependent upon the health system would be a fantastic place to start. And whether that comes from ground up, at the parish level up to the diocese, or if it needs to be led from the diocese and bishop's office, I think that that's a worthwhile pursuit.
Karen or David, do you have any thoughts on this aspect?
I think the only thing I would add is, David, Elliott, you're absolutely right. I keep wanting to call David. Elliott, you're absolutely right that every parish priest is dealing with it. And I think sometimes they may not know it. One of the mothers who is part of the family healing ministry shared with me one time that she always arrived to church just a couple minutes late, and she would leave just a couple minutes early so that she didn't have to talk to anyone. She didn't have to have anybody ask her, how are your kids doing? And have to either tell them how her kid was doing or come up with some other answer. She just was able to escape. So I think, when we see those people coming late, leaving early, I think we need to be mindful of that. And that's just I just wanted to bring that, every parish priest is dealing with it, whether they're aware of it or not.
Yeah, I think that a lot of the transformational implementation will have to occur at a conversation level with the USCCB or with the episcopate, where they know that larger numbers of spiritual directors are needed, which the Pope has said already, which needs to occur and needs to be trained and to be spread out. If you imagine every Catholic school having a spiritual director who is directly working with the chair of the theology department, how powerful that combination would be in a school for all of the growing young people that are in that school. I think that idea has to come from the bishops. Yes.
We have received a question that kind of dovetails off a little bit of this discussion. How do professionals work with pastors to get them comfortable with having, some kind of support or formal mental health system at the parish level? Especially, for pastors who, might not be inclined to do this kind of thing.
Yeah, so I'll first open this topic. So I collaborate with a lot of the priests who are in deliverance ministry or in the healing ministry in the Archdiocese of Washington. And I think that at the end of the day, them knowing and trusting that a Catholic psychiatrist understand their role, that we are instrumental in the work of Christ in the community, and that we know how to work as a team member and to be able to at times really take a back seat and to follow the lead of the pastor and those who are the spiritual directors or the priests who are doing the deliverance ministry. That actually matters a lot for them to know that, because too often they run into providers, mental health providers, whom take over and then ignore the importance at the local level, at the community level, at the family level, in terms of individual sharings with their pastor about how their family situation is going. So I think that's one of the key pieces, is the ability for the pastors to know that the mental health provider professional is able to set up proper boundaries and to not overstep.
Elliott or Karen, do you have anything to add in on that?
I just add one piece, and that's based on kind of my own experiences, that not only do they want to trust boundaries, but you call it integrity of the content that's going to be, are they going to be getting a message that is consistent in faith, aligned with the faith, so that I can trust basically handing off, my parishioner to this service is another component of where the opportunity would lie to build up kind of better trust, is to make sure that, and that's where I go back to my point around where appropriate, developing a positive set of treatment alternatives that's, explicitly or maybe implicitly, but just aligned with the faith, such that it's not like you're putting them out into a system that you don't necessarily trust. And I think that's an issue that can be addressed.
Excellent. Thank you very much. We've had a couple questions on this topic. Karen, I think that you might be the best person to answer this, but what are the existing programs out there for either mental health support or training in this, with this Catholic understanding, for addressing mental health from a Catholic perspective? And, are any of these programs, say in a seminary or being done for priests, et cetera, kind of talking about David's proposal there?
That's a great question. I can't answer what's going on in the seminaries, but what I can tell you from the faith community nursing perspective, the faith community nursing education is not strictly Catholic based. It's really for any and all faith traditions. I would lean toward looking at the Catholic Nurses Association, Catholic Nurse Foundation, and see what their suggestions would be. So I don't really have an answer to that great question.
All right, thank you very much, Karen. Does anybody else, Elliott or David, are you aware of any more information on that issue?
No, just one thought there. In terms of talking to my psychiatrist here, he said a lot of it is very local, that we need, instead of big national programs, focusing on resources available in your community is the information. If there's a core set of information that you need to be able to have to make sure that people are aware, that is where to focus, is getting to know the people in your community, the resources in your community, to be able to kind of help break down those barriers for access. That's a point that was emphasized to me as making sure that we really do understand that as a parish community, as a Catholic community, and the more that we can help grow those local resources, then the more better, or so much the better that we'll be.
Excellent. I think we have time for one more question, and this is another one that I think that all of you have touched on to some extent through your in your presentations. But the question is to what extent are the anthropologies of the church and psychiatry commensurable? And what are the main points of tension, and how do we resolve them? And kind of following up with that, are there, any magisterial documents that address mental health, or that would be particularly useful for getting an idea of the, perspective on mental health from Catholic anthropology?
Yeah, Philip. So I'm going to probably eventually lead back to Karen and Elliott, because I think Elliott already spoke quite a bit on this topic. But just to complement that, what has already been said, in the writings of St. Thomas Aquinas, there's actually a very well laid out anthropology, which actually have been further augmented by the work of Divine Mercy University, formerly known as the Institute for Psychological Sciences, on that topic, to kind of adapt it to this, most 21st century understanding of mental health issues. What I think is the potential confusion that has been introduced in more of the mainstream talk really stems from this kind of Enlightenment liberalism, kind of post-Cartesian dualism understanding of this mind that is separated from the person, which when you separate out the mind from the person as a separate thing, you have this potential pocket where you could create all kinds of contradictory notions upon notions within itself that actually doesn't really help us to fully understand. So if you really want to go back to a very clear reality and understanding of the human person, St. Thomas Aquinas lays it out very beautifully, and subsequent magisterial teaching, as well as research institutes like Divine Mercy University, have been able to fill out that space. I think the DSM and also a lot of the evidence-based work is really research-based. It's really manuals that were developed for empirical research at the high, like the university or NIH level, where they're looking at various different type of features to a condition and seeing what are the coherent parts that are tying together. That really doesn't have much bearing to the totality and the reality of a person.
So I will agree with David. Anytime you can go back to Thomas is a solid move. Again, he really does have a well-structured articulation of the human person, its orientation, its goals. And that's where I was kind of referencing earlier. You know, I remember having a conversation with, actually it was a extended family member who was going to be a clinical psychologist, just training. So it's a conversation with the student, so take it with a grain of salt. But I said, okay, well, that's an interesting field. You know, how do you define something as a disorder? And he said, well, if the patient's unhappy with it, or if society thinks that it's a problem. And I said, well, you know, what if the patient's not unhappy with it and then society doesn't say it's a disorder? Well, then it's not a disorder. Well, I said, well, that seems to be, you know, very much on a subjectivism basis, going back to the Cartesian kind of piece that David's talking about, of like, my mind says this is okay, right? I'm not connected or grounded to some objective reality. And that's where I see a potential advantage for a Catholic system that's understands kind of like how the human being is appropriately ordered and its drives, and from a natural law standpoint, you know, what's authentically good and fulfilling for a human person. You're going to find that there in Aquinas, and then that's a basis to understand what not only is a disorder, but what's properly ordered and how to move from one to the other, is at least some starting point. And then also from the integration of, you know, in psychiatry, to be able to use medications as a means to be able to help address mental health concerns. There, by appreciating that human beings are this nexus of body and soul, you're able to treat all dimensions of that person to be able to help resolve whatever, you know, ultimately spiritual issue it is, or it's impacting their spiritual health, because you can use medications, you can use the you know, discussions and kind of counseling, and it's all part of the same package, right? And I think that that's just a beautiful way to be able to appreciate the complexity of human beings and give you a solid basis to start from, kind of trying to help them. And I go back to this, it's so important because more than any other kind of field, this field impacts the ability of patients to make decisions. And how do you get to heaven but making decisions? So ultimately, at the center of this ministry is a concern for the salvation of souls. Health, you know, yes, we want them to operate well in society and be able to live fulfilling lives here, but ultimately it's about the, you know, the eternal goals. And here appropriately understanding the subject matter that we're dealing with, we're able to actually have that in mind and help them pursue that.
Karen, you got any thoughts on this to bring the webinar to a close?
No, I think the two gentlemen did a wonderful job explaining their answers. I just think we need to remember that we are dealing with a whole person and really need to focus on that idea of whole person.
All right, well, thank you very much for attending this webinar on mental health and mental disorders. Thank you very much to our three guests for sharing your perspectives on this. You will be able to find this webinar, some of the materials that the presenters gave, and additional resources on mental health and other bioethical topics at the NCBC site, www.ncbcenter.org. And again, thank you very much, everybody who attended, and have a wonderful day.